This is going to be a talk about chronic kidney disease and some of the complications that come out of what happen if you basically don't have your kidneys. So what is chronic kidney disease? It is characterized by a long-term permanent decline in renal function as measured by the glomerular filtration rate. So there's many different causes of chronic kidney disease, basically any of the things that we talked about in the tubulointerstitial section, anything that we talked about in the glomerulonephritis, diabetes, hypertension, any of this can cause chronic kidney disease. Approximately 17% of Americans over the age of 20 suffer from chronic kidney disease, and this number is increasing. There's a slightly higher incidence in blacks than whites. And what end-stage renal disease is, or you might see it written as ESRD, is it's simply the final stage of chronic kidney disease in which the patient is totally dependent on dialysis for survival. It's probably worth noting that the #1 cause of end-stage renal disease is diabetes mellitus combined with hypertension. Most patients have the two of them, so it's hard to tease them out. So the #1 cause for end-stage renal disease is diabetes mellitus with hypertension. So here's how we classify chronic kidney disease. They're classified based on the glomerular filtration rate, not on the symptoms. So this is really more of a way of organizing patients. It's not something that's used to guide treatment. Because if a patient has symptoms, then we're going to have to treat it accordingly. It doesn't matter what their glomerular filtration rate is. So stage 1 kidney disease is a GFR anywhere from 90 to 120. Remember, 120 is considered normal. Stage 2 is 60 to 89. Stage 3 is 30 to 59. Stage 4 is 15 to 29. And stage 5 is anything below 15. Stage 3 is very important. So if you look at stage 3, when does stage 3 happen? It happens when the GFR gets below 60. Once the patient progresses into stage 3, they're kind of at a fork in the road. They can get better, and they can stay in stage 1, 2, and 3, and in this case they won't need long-term dialysis. But if they keep going down past 60 and keep going down and down and down, and especially once they hit stage 4, these patients are going to be on dialysis. So you don't see patients that are in stage 4 go back into stage 3, 2, and 1 and hover in that area. Once you hit stage 4, it's just a matter of time before you're going to be in stage 5, which is end-stage renal disease. So that's why I put here in stage 4, these patients need to be prepared for replacement renal therapy, which is going to be either a transplant or dialysis. Another important tidbit is that whether or not you choose to dialyze a patient, it should be based on the symptoms at hand, not the patient's GFR. So don't look at the patient's GFR and say, oh, this patient's GFR is 80, but they've got potassium of 6.2 with electrolyte abnormalities, and they're highly edemic, and they're saying weird things and have a pericardial friction rub. That's not going to cut it. So you need to look at the patient's symptoms and not their glomerular filtration rate. So the best way to remember when we need to dialyze patients is AEIOU. And so A is acidemia, and this will be a metabolic acidosis because the kidneys can't excrete the acid. E is electrolyte abnormalities with EKG changes, and that with EKG changes is important. Simply having a hyperkalemia is not an indication for dialysis, but if you have a hyperkalemia with your peaked T waves that you see on EKG with hyperkalemia, that's certainly an indication for dialysis, because this patient now, with these EKG changes, they're at risk for arrhythmia. Intoxication, something we don't really see with chronic kidney disease, but important to know as far as when we need to dialyze a patient. That's salicylates, lithium, isopropanol, methanol, and ethylene glycol. O is for overload of fluid unresponsive to diuretics. We'll talk about that. And U is for uremic symptoms. And the symptoms of uremia are just the symptoms that are caused from having too much nitrogenous waste in the bloodstream. So those are going to be pericarditis, encephalopathy, or altered mental status. Other neurologic symptoms like myoclonus, severe bleeding, diathesis, especially in the GI system. So if a patient comes in and they have a low GFR and they have melena, or they have hematochezia, that would be an indication for dialysis. Okay, so this is kind of an overwhelming diagram. We're going to break this up piece by piece, and by the time we're done, we'll have looked at the entire diagram. So this is just kind of the diseased kidney and all the things it should be doing but is not doing, and then the highlighted things are the illnesses that come from that. So first we'll talk about hypocalcemia and hyperphosphatemia. So why do we get this? Well, the kidney is responsible for the production of 1,25-dihydroxyvitamin T, or vitamin D. So remember, the liver gives the hydroxylation at one part of the vitamin D, and then the kidney has to do it at another part. So then we have a vitamin D that's hydroxylated at two different points. And in order for the vitamin D to be active, it has to have the two hydroxylations. So if the kidney isn't working, we're going to have reduced production of 1,25-dihydroxyvitamin D. And what this vitamin is responsible for is it's responsible for increasing GI absorption of calcium and increasing bone reabsorption of calcium, increasing the activity of those osteoclasts that break down bone. And so it's responsible for maintaining our blood level of calcium. If we don't have enough of actively working vitamin D, then we get hypocalcemia. If we get hypocalcemia, what's going to happen? We're going to trigger our parathyroids. These little orange circles are the parathyroids. I don't know really what they anatomically look like. I forgot, so I just drew little pink circles. So if we have low calcium, we get increased parathyroid hormone. And what happens when we have a high parathyroid hormone? Well, it's going to try to increase the calcium, but we're not going to have the vitamin D to totally increase the calcium. But we will be able to increase the phosphate. So that's what's going to cause hyperphosphatemia. So we will absorb more phosphate. So we'll have hyperphosphatemia and hypocalcemia. Can't absorb the calcium because we don't have the right kind of vitamin D, which is made in the kidneys. We're going to absorb extra phosphate because we have extra parathyroid hormone, so we're going to absorb more phosphate. So what do we do? Well, this can result in osteodystrophy, so we want to keep that parathyroid hormone from being at such high levels, so we want to inhibit the production of parathyroid hormone, and this can be done with cinacalcet, which blocks the production of PTH. And then, in addition to that, we want to bind the phosphates. So our phosphate binders that we use are sevelamer and lanthanum. So you can use either or. Sevelamer or lanthanum to bind the phosphate, cinacalcet to block the production of parathyroid hormone. And this will get rid of our hyperphosphatemia. And hopefully we can ameliorate the hypocalcemia from that too. So anemia is because the kidneys are responsible for producing erythropoietin, and erythropoietin is simply what tells our bone marrow to make more red blood cells. So if we don't have erythropoietin at the levels we need, we're going to have a deficiency of red blood cells, and this will be a normocytic anemia. It's going to be similar to the anemia that you see in the anemia of chronic disease. And the reason is because we don't have a lack of iron, we don't have a disease of the blood cells themselves, we're just not producing enough. And so we have a normocytic anemia. And this you're going to see universally in patients with end-stage renal disease. So the symptoms for anemia are going to be fatigue and pallor, as I'm sure you can imagine. The labs are going to be decreased hematocrit and hemoglobin because we're not making enough red blood cells. But we'll have a normal MCV. The red blood cells are going to look fine. We don't have huge cells that we would see in a folate deficiency because they're getting arrested. And we don't have tiny cells that we would see in an iron deficiency or in a thalassemia. So you're going to have a normal MCV. So you have a normocytic anemia. And then you also have a normal TIBC. And why do I put that here? Well, because if you have anemia of chronic disease, you're going to have a low TIBC. So the TIBC is how we differentiate a normocytic anemia, as such would be caused by erythropoietin, from a normocytic anemia that would be caused by anemia of chronic disease. And so the treatment here will be erythropoietin replacement. Electrolyte abnormalities. The most critical electrolyte excretion products of the kidney are going to be potassium, hydrogen, and magnesium. So if we lose our renal function, it's going to be difficult to excrete magnesium, potassium, and hydrogen through the urine. So what happens when we have hyperkalemia? Well, this can cause problems with the heart, with the conduction system. So anytime a patient comes in and has hyperkalemia, regardless of whether you think they may have a problem with their kidney or not, any patient with hyperkalemia should get an EKG. But absolutely any patient with kidney disease needs an EKG if they have hyperkalemia. And the reason for that is because having a high level of potassium can cause conduction abnormalities, which can lead to asystole. So you'll get that EKG, and the treatment will be, if you do see the peaked T waves on the EKG, then you're going to dialyze the patient. If they don't have the T wave changes on their EKG, you can monitor them and try to get their hyperkalemia down, either by Kayexalate, but usually these patients will end up needing dialysis anyway. But on the USMLE, if you're given a patient with hyperkalemia and they have kidney disease and they say, what's your next step in treatment, you're going to say dialysis, or you're going to say get an EKG. If the EKG comes back with T waves, or it tells you that they have increased T waves, then you're going to dialyze the patient. So acidosis, this is going to be a metabolic acidosis because we're not getting rid of proton. And anytime a patient with pre-existing renal disease has acidosis, the therapy of choice is going to be dialysis. Hypermagnesemia is not really a big deal in and of itself. We just try to prevent this by keeping the patient on a low magnesium diet. And so this is an EKG that shows the peaked T waves. The best way to diagnose peaked T waves is to look at them compared to these big boxes. Each of these big boxes are 1 centimeter or 10 millimeters. If the T wave is any taller than 5 millimeters, it's considered peaked, a peaked T wave. So this is definitely a peaked T wave. And when I say 5 millimeters or more, I'm saying for the limb leads. So 1, 2, 3, AVR, AVL, AVF. So this is definitely bigger than half a big box. I don't really see one here. This is definitely bigger than, this is about the size of, this is almost 1 centimeter right here. So here you've got 2 definitely peaked T waves. So this would be an indication for dialysis if they had hyperkalemia and chronic kidney disease. When you look at the precordial leads, so V1 through V6, it's anything with a T wave greater than 1 big box or 1 centimeter. So this is very, very clear that the T waves are peaked. And really, if you can, in the clinical setting, you'll want to go to your precordial leads. They're going to show you the peaked T waves more prominently than your limb leads. So obviously, your V4 is like triple what it should be. This is more normal here at V6. Okay, and then here's just another one to kind of get that in your mind. Once again, V4 is sort of the most prominent. Okay, so uremia. We talked about uremia and azotemia before. Azotemia is just actually, azotemia is the buildup of nitrogenous waste in the blood, and uremia is the buildup of nitrogenous waste in the blood with symptoms. So azotemia may cause pericarditis, encephalitis, bleeding, or increase the risk of infection. Technically, uremia is when we start having those things, when we start having those symptoms. So a patient with pericarditis, encephalitis, bleeding, or increased risk of infection, we're going to want to keep an eye on these patients. Anytime a patient has pericarditis or encephalitis, especially if they have bleeding or they're coming off an infection, a really bad infection, we're probably going to want to dialyze these patients. Infection is very common in patients with dialysis, so we don't always dialyze patients with infection, but if they have sepsis or something like that, then we definitely need to make sure that these patients are being dialyzed. So what this causes, uremia itself will cause 4 separate things. It'll cause pericarditis, and that's simply because the pericardium is irritated from the nitrogenous waste products in the blood. It'll cause encephalitis, just simply because the nerves are also irritated by the waste products. It'll cause infection because the white blood cells cannot degranulate, and it can cause bleeding because the platelets can't stick together. And so what we can do, if the patient has just minor bleeding, like gums bleeding or increased bleeding time, etc., we can administer DDAVP, and what that will do is increase the von Willebrand's factor and allow the platelets to stick better. If they have a bleeding diathesis, particularly if it's a GI bleed, if they've got melena or hematochezia or hematemesis, then we're going to want to dialyze these patients. And keep in mind that infection is the #2 cause of death in patients with end-stage renal disease. And bonus points if you know what the #1 cause is. It actually is the cause of why they have the renal disease, which would be hypertension and diabetes mellitus. And then finally, fluid overload. So this is just inability to filter fluid through the glomerulus because of the reduced glomerular filtration. So this is directly due to the reduced glomerular filtration. If you have a decreased glomerular filtration, you're not going to be able to get fluids, water, extra water through the glomerulus and out through the kidneys. And so you're going to have excess water. That fluid is going to extravasate into your third spaces. And so what's going to happen is you're going to get edema. You can try diuretics in patients with stage 1 through 3 renal failure. These patients do have some renal function, so the diuretics might help them pee off some of that water that's in their skin. But most of the time, patients with renal disease are going to fail the diuretics, and any patients with stage 4 or 5 renal disease or end-stage renal failure, dialysis is going to be necessary. So you can try diuretics on patients with 1 through 3 renal disease, but if they fail it, or if the patient has stage 4 through 5, then you're going to need to dialyze them. And this fluid overload can get to be a really big problem, so you want to nip this in the bud as soon as you see this. So some long-term management for all the patients with chronic kidney disease. First of all, you're going to want to make sure that you have them on a restricted diet. So obviously they've got to keep their potassium down, low sodium and low phosphate. And while they're in the hospital, you can consult with dietary and make sure they're a lot better at making sure the patients know what foods to get, what foods not to eat, and how they can keep on top of that. So as far as USMLE is concerned, just make sure you know diet restriction is important for chronic kidney disease. Fluid intake restriction, usually it's between half a liter to a liter or whatever doesn't cause volume overload. And the patients also need to know that there is fluid in their food. So if they eat a big huge watermelon and a pineapple and oranges, you know, there's lots of fluid in that. So got to make sure that they're careful there. ACE inhibitors are renally protective, so those are always good. Lisinopril, enalapril, and captopril, and I really emphasize these for the patients with stage 1 through 3. Of course, avoid NSAIDs, as they're renally toxic. Acetaminophen is okay, and definitely avoid the aminoglycosides. If the patient does have a gram-negative infection, you can go with one of the newer glycylcyclines. Particularly the one that I think would be best for a patient with kidney disease would be tigecycline. It has great gram-negative activity, which is what you're trying to get with the aminoglycosides anyway, and tigecycline is not excreted through the kidneys. So that's probably the best one. It doesn't need any dosage adjustment either. So again, AEIOU, you should know when to dialyze a patient. That's based on their symptoms, not their glomerular filtration rate. We'll end with renal transplant. So survival is better with transplant than with long-term dialysis, and that's a lot because we've perfected kidney transplant through several decades of experience, and the drugs for that the patients take after transplant are actually very effective. And so post-op, they will need long-term indefinite therapy, and they'll take 3 different medications for their anti-rejection regimen, and those will be cyclosporine, tacrolimus, and mycophenolate. And they all reduce T-cell activity, and they are very effective. So survival is better with renal transplant than with long-term dialysis. And that is it.